Welcome everybody. I'm Clay Johnston. I'm the Dean of the Dell Med School here at UT Austin, and it's my pleasure to host the next panel. And it's on the challenges, opportunities, and what's next for healthcare with COVID-19. Obviously, we had some good news today, and so maybe that future is a little brighter this afternoon than it was last week. And we've got three great panelists. It's going to be fun session, and I know I'm going to learn a lot. One is Mark McClellan. Mark's director of the Margolis Professor of Business Medicine, Health Policy, founding director of the Duke Margolis Center for Health Policy at Duke. He's also a Dell Med faculty member as well. And he's got wonderful artwork and a nice cat. Over your right shoulder there, Mark. And then Zach Cooper is joining us. He's Associate Professor of Health Policy and Economics from Yale, and has been publishing a lot and presenting a lot on COVID. So great to have you, Zach.
No cat, alas.
I know, but we can't see the titles of your books. You got to put them up front so we can read them. And
I haven't read them, so your guess is as good as mine.
Well, you know, the ones that you've authored, you know, that's a good way to be selling your stuff. And then finally, David Lakey, who I think folks probably know, Vice Chancellor for Health Affairs, Chief Medical Officer, University of Texas System, and Senior Advisor to the President, Professor of Medicine at UT Health Science Center at Tyler. So, and David's been a critical part of the response to COVID here in the state. So we're going to start out, we're going to talk about where we are today, and then we're going to talk about where we think we will be in 2021. And David, why don't you give us sort of landscape, where are we, where's Texas today?
Yeah, it depends on where you are right now in the state of Texas. And let me start off with overall, kind of the overall Texas perspective, and then drill down to certain areas of the state. You know, we have reached a interesting time right now. We have over 1 million Texans that have had documented COVID. A lot of the data would say that you should have probably about 8 to 10 additional people for every documented individual. And so there's been a lot of COVID here in the state of Texas, and we are in the incline of a second wave with over 5,000 people that were documented with COVID in the last 24 hours. We have had about 19,000 deaths, had about 43 over the last 24 hours. And so the number of cases is going up, you know, and it's going up at about the same rate that it was going up earlier this year. But hospitalizations, although they're going up, are going up at a much slower rate. They are now, we have about 8,000 Texans in hospitals across the state of Texas. But again, that rate of increase it's much slower than in the summer. To put that 6,000 in perspective, if you look at the peak of the summer, we had 10,800 Texans in hospitals across the state of Texas. And at the nadir, at the bottom of the first wave, we were about 3,000 individuals. But again, that's Texas as a whole. If you start drilling down to regions, you get a very different picture. Specifically El Paso. El Paso is really challenged right now. If you look at their data, about 41% of all the hospital beds in El Paso, in that region, that trauma service region, are caring for COVID patients at this time. And if you look at the doubling time in El Paso right now, the number of cases is doubling about every 23 days. The number of hospitalizations related to COVID is tripling about every 25 days. And so they're on a very steep incline. But if you look here in Central Texas, it's a very different picture. We have about 3% of all our hospital beds right now that are related to COVID, and it's doubling about 182 days. And so West Texas, El Paso, the Panhandle are the areas that are hit most directly at this time. I have been very impressed by, it depends on who you are in the state of Texas and the impact that COVID is having on you. In particular, the people of color have had a disproportionate impact related to COVID. If you look at the overall cases, About 40% of the cases so far have been in individuals that are Hispanic. About 16% were in individuals that are African and American. The individuals that have died, about 55% of the individuals have been Hispanic individuals. I think a lot of this correlates to jobs. Essential service workers have, I think, borne the blunt of this outbreak. And I also think it depends on where you live. If you look at the data here in Austin, certain neighborhoods, certain zip codes, you see very few cases of COVID. And then if you go over to the east side of Austin, you see really profound levels of COVID in this community. When we talk to our hospitals right now within the UT system, they're doing pretty well right now related to the outbreak. They aren't seeing the supply chain challenges that they had in the spring. They have the personal protective equipment they need. They have ample amount of remdesivir to treat the individuals. Again, that's one difference that we have from now versus earlier, is that we now have a medicine. We also know that dexamethasone is helpful, and we've gotten smarter on how do you care for individuals with COVID. A lot of work is taking place right now in the state of Texas to be ready for a vaccine. Actually spent the last hour, actually 2 hours, on a panel put together by the state health department that has legislators, public health people, academics working together to figure out how we're going to be able to distribute a vaccine when it's available. As was noted earlier today, we have good news related to the Pfizer vaccine. The preliminary data that was released this morning said that it was 90% effective in preventing disease related to COVID. If that holds true for the rest of the trial, that's really good data and really good opportunity to prevent the spread of this disease. But we have to figure out, how do you take that vaccine from being in a vial on a shelf and get it into individuals' arms? And this vaccine will not be like our previous vaccines. It will have a lot of nuances of how do you handle it? How do you ensure that the first dose is exactly 21 days from the second dose if it's the Pfizer vaccine? If it's another mRNA vaccine, it might be 28 days between the first dose and the second dose. These mRNA vaccines, the mRNA itself is unstable, and so you have to hold it at an ultra cold, minus 70 degree Celsius freezer. And so a lot of logistics will take place in order to make sure that that vaccine is available to individuals across Texas and reaches those individuals that are most likely to get disease or have the most likely or are most likely to have severe disease if they get it. You know, one of the messages that I heard pretty clearly in the meeting I just came out of was that no shortcuts are going to be taken with this vaccine. We need to make sure that in order to have the trust of the population, we need to ensure that the FDA, and Dr. McClellan knows the FDA inside and out, but that there are no shortcuts that will be taken to make sure that this is a safe and effective vaccine when it is provided. I think one of the challenges that we are also figuring out we're going to have are the long-term complications related to COVID. This virus is different than influenza, and the receptors that it interacts with, where they are in the body. And so we shouldn't be surprised that there's additional complications for individuals that have had COVID and have been discharged, that the process isn't over, that there are a large number of complications. And a lot of health science centers are developing specific COVID rehab teams in order to care for the needs of these individuals. You know, looking out long term, you know, what can we expect? You know, I spent a lot of time looking at several different models for the state of Texas, whether they're the Michael Levitt model or University of Washington or UT Austin model. And that the take home message for me is that this isn't going to be over for a while, that we should expect this wave to continue through November, December, and into January before we can expect those numbers to start going down. And so again, I think it'll be very regional, but again, my expectation is that we'll see an increase in number of cases in hospitals across the state of Texas. And I don't think this really ends until we have that effective vaccine and are able to administer it to individuals and get to what we call that herd immunity of having about 70% of individuals that have immunity to this through the vaccine or through natural infection. So let me stop there, Clay, and hand off to our next presenter.
Yeah, thank you, David. So that's good. And hey, the disconnect between cases and hospitalizations, I mean, maybe more testing? I know we're doing a lot of asymptomatic testing, or is it that has the disease changed? I know they're seeing more mild disease too up in the Midwestern states.
I think part of it is dependent upon who is getting infected right now. I think earlier on, we had a large number of nursing home patients, elderly individuals that were more likely to have severe disease. A lot of the disease you're seeing now are in college age kids, and they're more likely to have a lower burden of disease.
Yep, good. Well, Mark, that sets it up nicely for you. And as David reminded everybody, you definitely have national interests. You were on the FDA, you led the FDA, you led CMS for a while. And you must be chomping at the bit, seeing all these new groups getting put together and.
Yeah, well, it's the definition of a pandemic is at the beginning you don't have anything that works. So what we're seeing now finally is some real progress, but just would reinforce what Dr. Lakey said about things getting worse, unfortunately, before they get better. This is definitely an additional wave, or I think it's part of the same, just another surge. We never really got COVID contained across the U.S. Since the spring. And what we're seeing now is more cases, especially in areas that were less hard hit before. So West Coast, East Coast, West Coast, the beginning, South, and you remember the surge in Texas in the summer, and now this is reaching other parts of Texas and the Midwest, and we've got the highest number of cases ever. They were down a little bit today. That's because reports are always down on Mondays. They'll be back up tomorrow, and looks like we're on track based on positivity rates in many parts of the country, many communities, to definitely the toughest surge that we face. And that's in spite of the fact that, as you're saying, a lot fewer people overall are being hospitalized with a shift to younger individuals in the case counts. All that said, we still got 55,000 patients nationwide hospitalized. The number is increasing, more than 1,000 deaths a day. The number is increasing. So these are going to rival because it's in so many more communities around the country, going to exceed the numbers that we saw in the spring. And just a reminder that we have better treatments and more sources of containment coming. Really need to be vigilant in the days and weeks ahead to get through what will hopefully be the last big tough surge in the acute phase of this pandemic. And that's where there is some good news looking ahead. And just to, again, pick up on David's comments, number one, the news on the Pfizer vaccine, while preliminary, is really way better than just about everyone was expecting. And this is preliminary. It hasn't been published yet, but looks real. It's on 94 cases. And basically with those cases, more than 9 times higher in the people in the placebo group than the people in the vaccine group. That did not happen by chance. Pfizer says that the effects are seen throughout the distribution of their population. And remember, the trials were designed to oversample elderly individuals, obese individuals, people from minority populations. They'll have more cases accumulated by the time they go to FDA for an emergency authorization application, but that is likely to happen based on these results very soon. I think they have 2 weeks, maybe more, of safety data collection to go, and they'll accumulate some more cases in that time. But I expect to see an application, if these results hold up, go to the FDA this month, before the end of the month, and then a pretty fast turnaround, a matter of a few weeks maybe at the FDA. They're going to have a public meeting, a chance for people to see the data closely and comment on it. If they do authorize the vaccine for emergency use, there will also be a review by the CDC and its advisory committee on immunization practices. But HHS at the federal level under Operation Warp Speed is trying to design a whole lot of advanced manufacturing and support for the very specialized kind of distribution that this vaccine will need, so that it could start within just a few days of that emergency authorization. which based on today's news should happen before the end of this year. And that's only going to be for the highest risk individuals, think individuals in nursing homes, other very high risk, some frontline healthcare workers. There's not enough doses for everyone, maybe 15, 20 million people by the first part of 2021. But it is an important start to the next phase of really building out population immunity and better protection in the population. By the way, there's no reason to think that the Moderna vaccine would be less effective. It's targeted against the same parts of the virus, the spike protein. And similarly for the vaccines coming along, and that Moderna could also, they're going to have a review very soon, could also be approved by the end of the year or close to it, again, with enough supplies for high risk individuals. AstraZeneca, Johnson & Johnson, there may be a few months behind, but first quarter 2021. And by that time, with a couple of other manufacturers that are also doing large scale advanced manufacturing and planning, could have broad supply reaching the US population as we head into second quarter and maybe to the point by the second half of 2021. Again, it's not going to happen overnight, just as David was saying, but sort of a gradual path towards increased immunity, assuming everything stays on track. And again, very good news today, but that's still a little ways off. There are a couple other things I want to emphasize in the meantime that could also change the face of the pandemic. The FDA has 2 applications before it right now for the so-called monoclonal antibodies for COVID from Lilly and Regeneron, which have also shown very good results in studies of patients who are at high risk for developing COVID complications if they get treated early in the course of their illness, soon after diagnosis, when they've started developing symptoms, but they haven't progressed to the stage where they're hospitalized and having some of the further immune-related complications. The immune globulins don't seem to, the monoclonal antibodies don't seem to work as well, and maybe even harm those patients, but early on can make a big difference. And that's a treatment that could start having an impact during this surge, the one that we're heading into right now. There are some important challenges ahead for, I know our audience is mainly health plans. These are treatments that are for people with COVID that will have to be administered via infusion. So think like cancer drugs and infusion centers. And obviously they can't go to the regular places to get those infusions. You're gonna have special centers set up with PPE and protection. So there are lots of ideas now being quickly developed about how to do that. And hopefully, Clay, something that Dell is thinking about. I've talked to a few people there about this, but these treatments could be available in limited supply as soon as, next week. The total supplies here are also limited in scale, several 100,000 doses by the end of this year, which you think about the math with, 125, 130,000 cases per day and a significant number of those in high risk individuals. You'd think that would be not enough of a supply, but the problem is administration. So not only distributing the monoclonals to where they're needed, but having these systems set up to administer them and identifying the people who can benefit quickly enough that they can still get the treatment when it makes sense. And this is, talking to people probably when you're telling them they have a positive COVID test, hey, you need to, if you have these symptoms, if you're in a high risk group, you need to come into a hospital, special facility or something similar. After we've been telling those people all along through this pandemic, if you're not that sick and you have COVID, stay home, stay isolated, don't go to a healthcare facility. So both in terms of getting rapid access to the needed testing, in terms of the education, engagement, and follow-up, and then actually having places set up to administer the limited supply of these monoclonals, which could, if you look at the studies, reducing hospitalization rates by 50% or more can make a huge difference in the impact of the current wave. Setting all of that up in the near term is going to be a challenge. And I think health plans, because the benefits are so great and there shouldn't be big barriers from a financial standpoint, you're going to get all the cost savings back on the hospitalizations, but just working with providers to set up these systems in the near term, hopefully doing it in a way that won't add to those very large health inequities that we've already seen. I'm really worried about, we're not only going to see it in caseloads, we're going to start seeing it in treatment outcomes. doing all that in the near term is a big challenge for plans working with healthcare providers. Third thing that's going to change the outlook in the near term is increased availability of testing. So Clay, you mentioned at the outset that testing in Texas is going up. It's becoming more available. Partly that's more availability of the so-called diagnostic tests like the lab PCR test, but also we've seen huge growth in so-called point of care antigen tests. These aren't quite as sensitive as the lab tests, but there is growing evidence when they are used repeatedly and regularly under good protocols that they can help. They're not perfect, but they can really help detect outbreaks earlier, because so much of the transmission these days is asymptomatic. So for universities, schools, already being used in sports leagues, et cetera, these tests are going to be much more available in the weeks ahead. And so with a good state and local strategy can also be an important way to enable more reopening, to enable kids to go back to school potentially as part of moving beyond where we are in the pandemic right now. It's a pretty dark spot.
Yeah, good. Well, thanks, Mark, for both it's not really pessimism, it's realism, but with a positive view towards a potential better future. So good. So Zach, we haven't really talked about the economic consequences, how this is, and our choices and how they've impacted the economy. So you've been writing a lot about this, and it's a really important topic. So can you, how are things now in terms of the impact?
Yeah, so, I think the first point we sort of make, and I'll unpack it, is that the first rule of pandemic economics is that you got to fight the virus. And I think, frankly, as I'll describe, in some ways we've pretty grossly underinvested in really our money to fund things like PPE or testing or the production of vaccines, the very things that are sort of going to get us out of a financial crisis. And I think one of the challenges is it's sort of hard to come to grips with the scale of the economic devastation that COVID has caused. And sort of three sources of it. One is the just direct economic effects. We sort of saw in those early days of closures, we were losing $17 billion a day. Over the next 10 years or so, the Congressional Budget Office estimates the economic effect of this is going to be about $8 to $10 billion. And that's, trillion. Once you're in the trillions, it sort of becomes hard to think about what that means, but it's getting up to about half of US GDP. When we think about the value of lives lost, it's a very, very scary number. All in, the best estimates are that the pandemic is going to cost us about $16 trillion by the time this is all said and done. And to put that in perspective, that's 90% of US GDP. That's as much as the US has spent in all military engagements, or significantly more than the US has spent in all military engagements since 9/11. It's about 4 times the scale of the Great Recession. So these are sort of enormous numbers. And one of the exercises we did early on was to take a look at how much the federal government had spent on COVID and then how that had been allocated. And we came to about 3.5 trillion, which is a tremendous amount, but about 8% of that was allocated to interventions that would actually directly stop COVID. We're spending hundreds of billions, low hundreds of billions, to fight a problem that's causing tens of trillions of dollars in damage. And I think that at its core is the problem, right? You just fundamentally need to up the allocation. I think the sort of metaphor here, the thing we need to sort of come to grips with is the reason we see a contraction in our economy is because of COVID. Therefore, the way to get the economy going again is to fight the virus itself. And I think the analogy that I often use to talk about this with legislators is imagine the boiler in your house went out. It'd be freezing cold. The solution isn't to just sort of burn money to stay warm, right? That will actually keep you warm, but it's actually to invest money in the particular interventions that would yield dividends. And, I think we've sort of talked about three issues in particular vis-a-vis how we allocate funding going forward. And it's what I'd like to see, which is a dramatic increase in the amount of money dedicated to, as Mark said, getting vaccine production up to scale. So I think the first issue is we've in some ways prioritized efficient production as opposed to just maximizing output. And I think what we really should be thinking about is how we get as much output as possible over the next year or two. I think that relates to the second issue, which is that there are some really particular market failures around scaling up testing and scaling up vaccine production. I think typically we think that firms recoup their costs in the long run for most things that they do, or their startup cost in the long run. The challenge is when it comes to vaccines or it comes to testing, we need more vaccines and more testing than we've ever had to produce over a very, very narrow period. And so over these sort of narrow periods, long run costs and short run costs are the same thing. And so we just need to be willing to pay much more per test or per vaccine or per monoclonal antibody than we've been willing to pay in the past. And I think that's just hard to get our hands around. I think the third is this concept of externalities. I do better when you're all vaccinated, but you don't sort of bear that benefit. And so the question is, how do we, as a country, address the fact that we all do better collectively when each of us is vaccinated, when each of us is getting testing, even though we aren't sort of willing to subsidize each other? And the answer is the government then has to pay for much, much more. And so I think one of the big questions going forward is who's going to be paying for testing? Right, so Yale is a good example. We're testing every student, I think, every 3 days. It shouldn't be private insurers who are going to be able to be subsidizing that testing. So who should pay for it? Well, big employers can, but many small employers can't. And I think that's where the federal government really needs to step in with more resources to allow places like small businesses or schools to successfully reopen and have the resources they need to do it. So our message is pretty simple, right? First rule of pandemic economics is you fight the virus. We need to understand the scale of the problem we're facing. It's about $16 trillion. That necessitates spending dramatically more than we're doing now to address the production issues that Mark highlighted. Different way to frame it, there just aren't that many vaccine production issues that $2 trillion can't solve. And if you told me that $2 trillion got everybody a vaccine 6 months more quickly, it would be worth its weight times 8.
Great. Thanks, Zach. So that's a really interesting perspective. I want to ask you a more mundane question, but before I do, you all can submit questions through the Q&A, and please feel free to do that. Now we're gonna just have an open discussion. We've got some questions here, but I think some of the things that you all said have asking a few questions. So Zach, one of the issues that troubles me, I totally get what you said, a GDP down maybe 90% based on total costs for COVID in the US. And yes, we can take dollars, we can get loans to cover those costs. But it's remarkable to me that those are huge loans, right? That we're going to pay those off for a long period of time. And I realize it's the right thing to do. You got definitely take out those loans. But ultimately it comes due. Now, what is going on with the stock market? I mean, I understand why it went up in the past, today, and it went up after the election. I get that. But why isn't it reflecting that at some point it's overvalued compared to what the GDP should be supporting? And I know it's just my disconnect and not understanding. Now you're going to clarify this for me, but I'm not alone in this. Why? And it has impact because it makes people think everything's fine. And there's a big, a big contingent in the US that thinks the economy is doing great.
So yeah, the Zoom was breaking up a little bit. So, a couple things baked in there. So I think the first is vis-a-vis sort of how we allocate our money. I think part of the reason I think we should be spending so much more on vaccines and spending more on testing is precisely so that we're not offering aid in perpetuity.
Mhm.
And I think what we have to realize is there's just so many people out there who are hurting so tremendously. And the sort of solution isn't to just keep pumping aid out forever. It's to basically get us out of the
Got it. So get us out of the hole and avoid this dip.
hole that we're in. What I use people to ask that question is, imagine you sort of had a patient on the table who was bleeding out. You really wouldn't be concerned with like the widespread blood supply available in 5 years. You sort of say, look, we got a patient dying, we need to give them blood now. I think
Well, Zach, Yale, we know, is at the cutting edge, but apparently not in its Wi-Fi systems. So
the economy, if we don't, the interest rates are zero. So you sort of have a choice about buying treasuries and getting nothing, or sort of speculating on the future with the stock market.
good. Thank you, Zach. I'm sorry, you're breaking up, and so we get it in these like zips, like you can talk incredibly quickly and then you go quiet again. So Mark, this is clearly impacting the healthcare sector in interesting ways. And now take off your FDA hat and put on your prior CMS hat, and tell us a little bit like who are the winners and losers here, and what's going on with the healthcare system.
Well, it's a great question. And I think first, everybody in America has seen how much healthcare providers have stepped up to deal with the pandemic. I know in the tough days back in the summer and in Austin, just how busy everyone at Dell was, and that was happening in the Valley, Houston, many other areas of the state, and it's still happening, as David mentioned earlier, out in West Texas, El Paso area, and High Plains. But if you look nationally, so we've seen health professionals step up, and now they're fortunately better supplied than they were in April, and more chances to plan. The organizations that have done the best, Clay, are the ones that weren't so dependent on fee for service and admissions for all of their patients. So we had like two really bad things happen this spring. We saw this big surge in cases to the point where we went into national shelter in place. And at the same time as that happened, the revenues that many of the healthcare organizations that are paid for in the traditional way, those went through the floor, 40-50% reductions with the suspension of elective procedures. Now, CMS stepped up with providing some flexibilities. Congress stepped in with a couple $100 billion in assistance. But I'll pick up on the analogy that Zach was doing about the furnace, in that there were a lot of organizations that weren't being paid that way. That's a minority of those in the U.S., but think about like some of the more integrated delivery systems, some of the programs that Dell has started, and working with some of the, especially some of the more vulnerable populations in Austin, and what organizations in advanced accountable care groups or more direct contracting arrangements around the country, where they get paid more prospectively at the person and population level. Those organizations prior to the pandemic had done more investments in activities like telehealth and tracking their patients longitudinally to help them stay out of the hospitals. They worked often with health plans, including many of the health plans represented in this group, to get paid more. When they implemented these reforms, they got total costs down, they got to better results. Those organizations had sort of the exact opposite experience at the beginning of the pandemic. They didn't face the reductions in revenues. They weren't pressured to really reopen elective services, except the ones that were most needed. And they were able to focus a lot more, not just on finding ways to make ends meet, so they didn't have to lay off staff, but to actually implement further steps in telehealth and home-based services. So, winners in this pandemic, the silver lining here is that we've seen a big shift to telemedicine. We're doing a lot of things outside of the hospital and at home that we didn't think we could before. Behavioral health, I think, has changed forever. Some aspects of telehealth, but we've also seen a lot of care kind of snap back because organizations that didn't have a better path forward have really had to focus on reopening, kind of the way they were doing things before, which is challenging to do in a pandemic. My hope is that we're going to see more win-wins, not win-loses coming out of this. There are a number of health plans around the country that have implemented steps to help out their providers. And I'd say this has been most true for primary care providers who are really hard hit. And those numbers haven't come back, by the way. We're still running 30% below, 30% below levels for screening tests and kind of chronic care management, even accounting for some of that being made up for in telehealth. Significantly fewer mammographies, significantly fewer colonoscopies, significantly fewer vaccinations than the previous baselines. We've got to get that fixed, or we're going to have even worse health consequences. So some health plans, instead of doing sort of the initial federal government approach of just providing relief, done it in two steps. Some upfront payments to the groups that are struggling now, but then helping them move into an alternative payment arrangement, something more like a direct contracting or advanced ACO or another model of payment. So Blue Cross in North Carolina is doing that, Blue Cross in Massachusetts, Blue Cross Minnesota, Optum to some extent. So that we're reopening not with the same old healthcare system as before, which was not well prepared at all for this pandemic. It's not the way you want to be paying and organizing care. And instead, building something that's hopefully more resilient. So I hope we can see some lasting impacts on the healthcare system. It is going to take health plans paying a different way and meeting their providers. Again, like health plans have really stepped up in providing some short-term relief, advanced payments and so forth, but not just thinking about how do we get through the next month or two, but how do we get on a better course for a more resilient healthcare system for the future. I have the privilege of working with public-private collaboration that CMS sponsors, the Healthcare Payment Learning and Action Network, which again includes a lot representation from a lot of the health plans represented here, that set up a resilience collaborative with a lot of examples of exactly the kinds of changes in payments and approaches to dealing with care at home, to dealing with social factors that influence health outcomes, to dealing with these huge racial and ethnic disparities that have emerged. All of that is easier when you're not as dependent on traditional fee-for-service payment, and when you're able to see a path forward. It's hard to redesign care, but we've got more examples than ever before of how to do this successfully. So I'm hoping that that's going to be a sort of a net win-win, a silver lining from the pandemic as well.
Good. And so you're sort of taking us a little bit to silver lining and thinking about the future. So where are we going in the future? So David, what does it look like? What do you see? What are we going to do differently at a state level? How is this going to make us stronger?
So we've already brought up telemedicine. I think, we were doing a lot of work trying to get telemedicine to really take off like in other states prior to this. I don't think we're going to take a step back. When you look at the volume of telemedicine visits now, the satisfaction that people have related to the telemedicine visit, I think telemedicine is going to be a big chunk of healthcare delivery in the future. Now, one of those areas that it really has been helpful in is in mental health, but also in substance abuse services. I think we have moved forward significantly in providing people compassionate substance abuse services through telemedicine, and because of a variety of waivers, et cetera, that were put in place. And hopefully we get better with that. Hopefully we can do a better job at addressing this major issue in the state. I think kind of on a different aspect though, Clay, we talked a little bit about the catch up that we need to take, that needs to happen with vaccines, colonoscopies, et cetera, all that preventative services. The other unintended consequence of the response I think we need to be very cautious about is the loneliness and the mental health and depression issues that are taking place right now. There are a lot of lonely people because they haven't been able to see their grandkids, haven't been able to see their family, the isolation that has taken place. And if you think back a year from now, what were we talking about related to public health? We were talking about loneliness as being a public health issue. There was work at the CDC, work at HRSA. I have a diagram, a cartoon that the CDC put together, emphasizing that being lonely is equal to smoking 15 cigarettes a day. There are significant consequences, increases in dementia, how it goes up when people are lonely. And I think that's an area that we're going to need to have a lot of effort in over the next several months as we get through this and afterwards, addressing the mental health, the substance abuse services, and how do we address that. The other thing I would add, Clay, is I don't think this is the last pandemic that I'm going to be in during my life. I was at DSHS during H1N1. There were other major infectious disease outbreaks that I was a part of. If you look at coronaviruses as a whole, over the last 20 years, there's 3 of these that have jumped to humans: SARS, MERS, and now COVID-19. We need to invest in basic public health infrastructure so that we are better prepared for the next one of these that will occur, I believe, in my life.
Yeah. I mean, that's it. We say this after every major outbreak, right? And then we do it for a few years and then we stop doing it. It just shows how sort of short-minded we are. That loneliness thing is critical. We did a really interesting randomized trial to show that a really simple intervention, just having people call folks that are isolated, has a huge impact on loneliness. We know it, right? Because we remember to call our parents, and it's so important to them. And if your children aren't calling you, then if somebody else does, that can also help. All right, Zach, back to you. So first, don't you hate Zoom? I mean, that's got to be my first question to you.
Well, so this is my first day back in the office, and it looks like Yale's not paying our internet bills. So now I'm on
that's what we were saying.
my iPad.
Cutting edge in so many ways, but not in their either internet or Wi-Fi, whatever it is. And because of that, you didn't answer my mundane question, which is, why isn't the stock market down? Just answer it in one sentence or 2 sentences.
Yeah, so 2 sentences: stock market reflects the future. And then I think the other is the economic devastation is so bad that there's not really a good place to park your money. So when interest rates are super, super low, you need a return somewhere. And if it's not coming through the usual suspects, the stock market starts to look more appealing. I think the others, it's again, super important to say the stock market isn't getting further and further away from the rest of the economy, right? Stock market just isn't a bellwether. A different way to say, I think the best way we could judge our economy is sort of median household income right now.
Mm-hmm.
And, that obviously looks a lot different than the picture we get presented with the stock market. And I think one of the things that we forget, and I think it's true for a lot of the experts like us who talk about COVID, is in a sense, like, my life is not that dramatically changed by the pandemic. And I'm working at home. My significant other and I are maybe like going after each other a little more because we don't have space, but we're not seeing our livelihoods taken away from us, and we can still work, which gives us purpose. I think most, a large share of the public doesn't experience that. And I think those folks often don't have a voice. And it's just sort of easy to lose sight of what their world looks like and how dramatically it's been transformed in a very short period.
Great, good. And so now let's move you to the future too, Zach. So I don't know, are we going to learn the economic lessons from this one? I don't know, right? The lesson that you're, stop the bleeding before you worry about the emergency room bill. What are we going to learn? How can we learn from this?
Yeah, I mean, I think I'll pick up a little bit from what David and Mark were talking about. So I think the first thought I have about where the health system goes going forward is sort of do no harm. So I think there's sort of a real risk of shotgun sort of closures / acquisitions that reshape the health system going forward. And I think the antitrust authorities just really have to be on their toes looking out for that. I don't think we want a reshaping of the health system because we're in a hole that we wouldn't have otherwise wanted. I think I agree with David. I think telehealth is here to stay. I think where the jury's still out, and if there was a question I really would want to look at myself, it's that we've had a huge slowdown in access to care. I think it's going to be a good opportunity to see how useful that care actually was. And I suspect at the end of this, it's going to take a couple of years, we're going to find out that a lot of the medical care that we thought was imperative actually wasn't that imperative. And I think it's going to be interesting to see where we settle on sort of what care is useful and what isn't. And I think I'd like to think, the evidence base, frankly, on the efficacy of most treatments is just not as high as we think it is. And I think that might be one of the sort of enduring legacies.
Yeah, that's going to be interesting, though, because the other possibility is that we see a whole bunch of advanced colon cancers and metastatic breast cancer and because we haven't been doing the routine screening.
Right.
Yeah, I mean, I'm a stroke doc. I'm a stroke neurologist, and I definitely in this acute period, avoiding care for an acute stroke is not in a person's best interest. Right. Economically, it's probably cheaper for society because it does sometimes lead to death. Not always, can lead to disability. Deaths are cheap, relatively, at least in the folks who get stroke. But honestly, the data that's coming out now about 20% reduction in people showing up acutely for stroke, but then increases in stroke mortality. It's going to be very interesting to see how this all pans out, right?
And I don't know that we know where people are. Like, I don't think we know exactly what's happened to them, why they aren't coming in, and what their outcomes are. I think there's going to be an effect of lower road travel. I think, we've seen a really big shift in the environment, the amount of pollutants in the air. We're going to have to sort of take all of that stuff and use it as an opportunity to see what we can learn.
I think that's a great example. I mean, the other one is, we're a level 1 trauma center. Trauma is way down, right? Because people aren't driving and they're not as active. And so, that has a health benefit. We can take a few questions too from the Q&A. So if people want to put in questions, Mark, you addressed one online, but I want to go back to it because I think it is useful. This is now putting your FDA hat back on, children and vaccines. So, children are getting COVID. Are they going to be able to vaccinate them, and when?
Not anytime soon. The kids were not included, at least under 16, 17, were not included any substantial numbers in any of these early large-scale trials. And that was a conscious decision guided by the FDA based on the fact that the risk to the individuals involved from COVID was demonstrably much lower for kids, fortunately, I guess, than it is for adults. So we started with the higher risk populations, young adults on up. And my expectation is that after we get a lot of data on safety as well as effectiveness of vaccines in the adults, you'll see some add-on studies looking at kids. Pfizer's actually started one for kind of the teenage age range, but they're not going to be part of the initial vaccination round. So, later 2021 at the soonest.
Perfect. Good.
Clay, can I jump in real quick?
Yeah.
I think one of those other silver linings, so to speak, related to this is I think vaccine technology is going to move forward significantly. And so these mRNA vaccines, we really haven't had a commercial mRNA vaccine before. And I was encouraged by a recent New England Journal of Medicine article where they looked at the immunogenicity of these mRNA vaccines in elderly individuals, and they were as good as they were in younger individuals. And so this may be an opportunity to really catapult vaccine technology for older individuals forward significantly because of some of the lessons we're learning through this.
Great, good. So we haven't really talked about prevention. I mean, usually that's what we're always talking about, right? Wear the masks and social distancing, and should bars and restaurants be open and all that. And obviously we have understood what the federal stance is going to be on that. And it is likely to change. So how do you all see that rolling out? And what kind of impact is that going to have as the vaccine's rolling out? Is it, and Zach, why don't you start? Because you've got a strong view on this that's really important.
I don't know that so I think two quick thoughts on the question. So I think one, there's a period I'm most concerned with, like the next 3 months and what we do, because I think we're seeing cases obviously go up. We need to keep our sort of fingers on the pulse. I think we just need to start trying to get money to states as quickly as we can right now so that they have the tools if we're not going to see anything from the center happen. I actually think the data on masking is pretty extraordinary. You know, that if you can just get the share of mask use up, it's actually remarkable how quickly it lowers transmission rates and then can sort of cool down hotspots. You know, I think if we can see that go up, that's an amazingly good thing. You know, again, I'm of the view that sort of everyone should do it, not for me, but for everybody else around me.
Other thoughts on that, David or Mark?
Yeah, I think masks really are extremely effective. And unfortunately, they became a political issue. But when you have data such as what occurred in Missouri, when 2 infected beauticians cared for 139 individuals, but they wore their mask and none of the 139 developed COVID, or you have some of the data that Vanderbilt has released showing the stark differences between communities that required a mask and those that didn't, and the number of people that were hospitalized. Yeah, we are getting significant evidence of the effectiveness of these masks, and it's a really cheap, effective prevention tool. You know, Barry Lockman put the question in there of what can we do to prevent, and the old removing the pump handle, and I think the mask is that way, coupled with good testing. And we've talked about testing. I'm encouraged that we now have cheaper tests. They're not readily available yet on the market, but the Binax Now $5 result in 15-minute tests, coupled with other tests like that will be made available, will bring down the ability to do really that population-based analysis that we need. And then we can start doing better contact tracing. You know, right now it's really hard. And in the summer, it was really hard doing contact tracing if you're getting lab results late. You know, once you have point of care analysis of whether people are infectious or not, you can immediately bring contact tracing and prevent that chain of transmission that is so critically important.
Great.
Yeah, just to build off David's point for 1 second, I think one of the hardest issues across the board, the policy issues we struggle the most with are issues where my actions affect others. Right? My smoking affects you. It's really clear that like I shouldn't smoke to affect me, but like what do you do when it's my actions that affect you? It happens with neighbors, right? My neighbor doesn't mow his yard or paint his house. I get pissed off. We all have a fight. That's what we have right now, right? We have an issue where our individual actions affects those around us, and the policy issues around that are really, really hard. I think what's really important here, though, is that economics gives us a set of tools to address those, and in a sense, it's subsidies. Right? You want to sort of lower the cost of doing the thing that helps those around you, right? So sometimes we've sort of used the stick to get people to use masks. You know, what if stores said, we'll offer you a 30% discount if you come in wearing a mask? You know, what if we really heavily subsidized testing? I think that's where this sort of, if there's a real intersection with the insurance community, who should be subsidizing this stuff? Because that's what we need to do to get people to do it. And that's really where I want to see federal action. We need to lower the cost of people doing the right things so that they can help those around them. It's just really hard to do.
On those policies, I do think attitudes are going to change, and unfortunately, it has been, has been politicized this fall. If you look at what I guess I can say President-elect Biden has been saying, even today, talking about working directly with states and governors on mask mandates or something approaching it. It does make a difference. We do a project with data from Facebook and social networks on how people are acting, decisions about wearing masks and so forth. And there's a strong correlation between the rate of spread in some states and mask wearing and other similar behaviors. And maybe that masks attitude is picking up some other behaviors that people are or aren't doing that affect the same kinds of transmission that Zach was just talking about. But it's still our best hope for the current wave. And while I don't know about discounts, Zach, for going in the store, I don't think the store should let you in at all if you're not wearing a mask.
Yeah,
but,
you and I are on the same page.
You know,
on that.
Texas tried a bit with testing. Dave, you remember, like distributing masks to people over 65 and at some sites, more of that. So free masks, subsidies, things that remind people and make it easier to do the right thing and make it more of a cultural norm. Will hopefully make a difference. Those norms are hard to change super fast, but something about, you know, the cases really skyrocketing in your own community, it does affect people's behavior in places like El Paso. You know, there are restrictions that have been put in place locally. We're not going back to a national lockdown, but I fully expect to see a lot more places doing what El Paso has done, regional restrictions. Chicago's doing it, Newark's doing it. You're going to see more of that in the coming weeks, and people change their behavior. They go out less, they do less. Back to Zach's point about what really affects the economy. Well, being afraid that you're going to get COVID or somebody you love is because it's really rampant in your community does. So hopefully that'll get people's attention in the near term. I'd like to think that we'll get there on testing and contact tracing. Part of the challenge is that, you know, a lot of Americans are not so keen on giving that level of information to anybody they don't know. The other problem is still going to be helpful to get the diagnostic testing up and to try. But the other problem is that so many cases now are asymptomatic, and most of the transmission is asymptomatic. So that's where the regular screening test can potentially help a lot. And there, to Zach's point, we've been working with support from the Rockefeller Foundation on a national effort towards a national strategy for testing. The technology is there. This is not something that health plans would primarily pay for. You know, they're paying for the diagnostic test for people that you suspect have cases. This is more general screening done in a sports league, a school, a university, an at-risk workplace. We will be producing in this country probably close to 200 million of these point of care tests per month by late this year. And if we can just implement protocols to using these tests as an additional layer of protection, that will support more reopening. Had an op-ed in the Wall Street Journal last week about how even though cases are going up, it looks like with some effective planning, we should be able to reopen schools on a broad basis by early next year. It won't be the same. Still have to do distancing, plastic screens, masks, and perhaps at least some testing. But early results in districts, including in North Carolina, that have started tracking this, suggest that student to teacher transmission in these circumstances is really low. Testing provides additional help. And kind of thinking about national priorities, France, England, they've shut France and Germany, they've shut the bars, the schools are still open. Here, I think we can do more to get this right too. It'll take some federal effort, some federal support, but I think we can do a lot better in the short term.
Yeah, we've got to finish up where we promised everybody a break, but they're not quite getting it. But this has been a great conversation. That's a great way to end too, Mark, that schools could be in session normally next year, and maybe the chance that this meeting will be in person next year. What do you think? Everybody thumbs up on that one, or any thumbs down? Don't think it's going to happen? Oh, Zach's not sure. Mark, you're not sure? Oh, come on.
I think we'll be in a better place on COVID, but social norms are changing about meetings, Clay.
All right. Well, thank you all. This has been a great discussion. It's been.
It looks like it will be in person, so according to Jamie.
Yes, it will. Jamie said. So. All right. So everybody. Thank you for joining us today, and thank you all panelists, and look forward to seeing you in person next year.
Thank you.